hopefully this will be just a review for you. So what I'll try and do is to go through these. There are 3 presentations to try and get us through most, but probably not all, antibiotics, and try and do it by class and then get more eclectic with just single agents as we go along. Obviously this is really important because this is what everybody does who does ID on a day-to-day basis. If it's not this, it's antiretrovirals. So usually we're doing, or antivirals, one of those 3 classes, or antifungals, which we haven't really got to. Since I was tasked with antibiotics, that I'm not going to include antifungals in this, or else I would have taken the whole morning, but... Did she? Okay. So just to get us through this, the first one are Beta-Lactam antibiotics, and most of you know that the area of interest for that is the cell wall, and they interfere with a formation of a rigid cell wall, whether it be in gram-positive or gram-negative bacteria. They can be very narrow to very broad spectrum, and all of them have, which is a little tough to see on this, but that wonderful beta-lactam ring. So if you open it up and just break any one of these bonds, you pretty much inactivate the antibiotic. So we have, I think, most of the beta-lactam classes on here. The only one that I have listed on here is Astrianam because that's the only commercially available monobactam. Where did the word monobactam come from? Do you know? Yes, it's a monocyclic beta-lactam antibiotic. That's why they call it monobactam. There actually was a purpose to the name, if you could believe that. And it's been kind of interesting when you talk to people about how to remember. If you were drawing these out, remember that beside the beta-lactam and penicillins, it's a 5-ring structure. So if you will, it's like a house, and there's the chimney, because there's the smoke coming out of the chimney, if you will. A cephalosporin, same thing, except now it's got a basement, so it's a 6-member ring structure. Carbapenems are a house, but this one's a cheaper one because there's no chimney, there's no sulfur in this, so no smoke coming out of the chimney. It's just kind of a way, so if somebody shows you a structure and you can identify it as looking like a beta-lactam because you see the beta-lactam ring in it, is it a penicillin, cephalosporin, carbapenem, or if that's all that you have, nothing else attached to the beta-lactam ring, then it's going to be a monobactam. So you can ask Dr. Sennett in his travels. One time somebody asked him what he was using in the United States, and to rattle off a variety of names, and they have, of course, no idea the brand names that he was talking about, so they show him a chemical structure. This is what we use. And he said, that's great. It's tough to know what is it, unless that you can actually look and try and figure out what is it. So it is a good thing to at least have some idea of what these things look like. You never know when they'll show up on someone's board exam somewhere. So what do they bind to? I'll give you a hint. They bind to penicillin binding proteins. What's the purpose of these proteins? To bind penicillin? No, that's not. They were named because that's where it was identified that the antibiotic, the first one's out, penicillin, actually stuck to, but these are enzymes. And they're active in formation of a cell wall. So without having penicillin binding proteins, you can't get cross-linking of peptidoglycan chains. If you can't get that, you can't synthesize a stable cell wall. The pressure inside of most bacteria is greater than on the outside of bacteria, so they tend not to do well. They either explode, or if it depends on which penicillin binding protein you inhibit. Sometimes you get these long filamentous bacteria, almost spaghetti-like bacteria, that then can't replicate because they can't form an inclusion and a separation point, so that the bacteria just can't function that way either. So it depends on which antibiotic and which of these penicillin binding proteins that we're talking about inhibiting. So if you're looking at what really is happening here, you're, as you see, combining these 2 structures together. These act as a transpeptidase, and that's what in fact that penicillin binding proteins facilitate is transpeptidation. So when you're looking at the structure, that I'm sure you probably would have already been able to tell me, showing you this ribbon structure, you would have said, well, obviously that's a penicillin binding protein. And if you could, I'll let you come over and do the talk while I take a break for a while. But here's the transpeptidation domain, and this is a PBP2A from a Staph aureus. So these can be a little different. The configuration is a little different. So if you're looking at an antibiotic that's going to bind to these sites, these enzymes, and keep them from acting, keep them from functioning, sometimes subtle changes in penicillin binding proteins can inactivate antibiotics, which is what you see with community-associated MRSA, because their PBP2A is a little different. And I'm sure you'll hear more about that. Why am I, and we don't really have enough time to even go over resistance the way that I'd really like to go over resistance. You absolutely need to know mechanisms of antibiotic resistance. Why do you need to know mechanisms of antibiotic resistance? Because it's going to be a big push on the ID boards. One of the individuals who I know quite well, who's out of LSU, is Dr. George Karam. George is nationally and internationally known and has done quite a bit of work not only with their residency program at LSU, I think George is in Shreveport, but in his work and insight into resistance. And this is something that was really hot when I was a fellow, but it's kind of fallen all apart once HIV came out and became the main thrust. And then with less and less antibiotics coming out, you didn't hear the same people telling you about why this antibiotic has advantages or activities against certain bacteria that maybe others didn't. So this is a real important thing that we need to keep going over, especially for this year and continuing on for people just starting. For those of you who will be finishing this year, maybe you will, maybe you won't, who knows. No, I don't know anything you don't. As Aaliyah's looking at me like, now what did I do? But this is the main function of penicillin binding proteins, is to basically create the scaffolding of cell walls. And it depends on whether it's gram-positive or gram-negative, because here you can see the gram-positive cell wall down at the bottom of this slide, and noticing that the gram-negative cell wall is a lot more elaborate. My crude way of thinking about this is, with a gram-positive, if you cooked up a pot of spaghetti and kind of tried to stack it in there very nicely, so if you could get it arranged kind of with some of this more linearly and things, and then took it off and threw it into a colander, and all this is more probably, I guess, like lasagna, if you want to think of it that way, and let it cool like overnight, and then throw it onto a cutting board and slice it down the middle, it might look something like this. Where if you look at gram-negatives, they have the same type of structures, but they have the outer lipid membrane, and then the peptidoglycan layer is more in the middle with a periplasmic space in between. So in a way, it's like a castle that is protecting the castle parts in here, and the moat is in through here. And resistance can happen on the outside with this, because you can make beta-lactamase, which is actually extruded out into the environment, into the milieu. It's fairly concentrated in the periplasmic space on gram-negatives for most of those. So a little bit different mechanisms for resistance, and gram-negatives have some other ones as well that are fairly important too. So when you start looking at some of these, you know, there we go, couldn't get it to change. So this is really what we're talking about a little closer, is with this layering and scaffolding of teichoic acid, lipoteichoic acid together, with gram-negatives having this periplasmic space that's in between, and also structures on the outside with porins, which are small channels that sometimes antibiotics, nutrients, or other things can get in and out of the cell, but they can actually move the porins, change the size, change the caliber of the conduit in the porins, and sometimes big molecules then don't fit too well. So another potential area of resistance. And not only that, but just to mention that some of these can also have pumps, efflux pumps. My way of thinking about an efflux pump is a bilge pump on a boat. If you have a boat, most of us, if you were on a boat, would like to be above the water, because if you're above the water, you're having a good time. If the boat's full of water, you're not having a good time, you're sinking. So you need a a good bilge pump to keep the water out of the boat, because all boats leak to a certain degree, or water slops over the side, or whatever. So if you keep the water out, and a lot of times these things are pumping it out as you go along, then everyone's happy. The same kind of things with bacteria is with certain bacteria, with certain antibiotics, they can actually pump the antibiotic out about as quick as it gets in. So if it's an antibiotic whose site of action is inside either ribosomal or other enzymes inside, if it can pump those out before it gets to its target, then it really becomes ineffectual. But if some of these antibiotics are very potent, if they can overwhelm the pump, then they can work quite well as well. So some of these are not quite as high level resistance, a little lower level resistance. The other thing important to know is the pharmacokinetics and pharmacodynamics of the antibiotics in the classes. That beta-lactams are time-dependent killers, where others are more concentration-dependent. Some have a post-antibiotic effect that's pretty long, some have a relatively short post-antibiotic effect, and some have no post-antibiotic effect. So what does time-dependent killing mean? Yes, unfortunately no one has glasses to read the slide. So basically what you're looking at is beta-lactam antibiotics have to be around for them to work. And usually people talk about 2 to 8 times the MIC. So you need more than it takes the bare minimum to kill the bacteria. But once you get to a certain threshold, you could add 16 to 32 to 128 times the MIC to 1,000 times the MIC, and the killing gets no better. So once you get to a relatively low threshold, the killing doesn't improve, but you have to have the antibiotic hanging around. Because remember that these cell walls, whether it be gram-positive or gram-negative, are constantly remodeling, and in some ways they're like bone. You look at a piece of bone and think it's this structure that probably never changes, and we know that bone remodels itself all the time. So bacterial cell walls have to do that as they're dividing. Some divide relatively quick, 20, 30 minutes. Some take a day and a half, depending on what it is, or sometimes even a little longer. So these antibiotics have to hang around long enough for them to get to the site of attachment to penicillin-binding proteins to be efficacious. So with time-dependent killing, you're really looking at the duration that the antibiotic is around. So the time over the MIC is what's predictive. Concentration-dependent tells you what? The more you give, the better it works. It could be around for a short period of time, but if it's at a high amount, high concentrations, getting to the target in high amounts, it works very efficiently. So that's the difference between some of these, and these are bactericidal as far as beta-lactams go, that they do kill bacteria. So what we just talked about is what you see on this graph, that this is the time greater than the MIC. This is basically what you see with time-dependent killing. Concentration dependent depends on how high this is. So with time-dependent killing, it's beta-lactams, tetracyclines, and who can say the last one fast 5 times? Oxacillinones. Yes, it gets. You almost feel like you're speaking Spanish when you're talking, because you start rolling like oxacillinones. Not an easy word to say. So, but those are the ones that are more associated with time-dependent killing, and the others are associated with concentration to some degree, and then some of these have a post-antibiotic effect where that you still get killing even after that the antibiotic is below the MICs. So just to give you, and I'll get you handouts on this as well, so don't worry if you don't get something written down. But I thought this was probably the best way to put it together so that you can remember what's going on. Is what falls into time-dependent with little to no post-antibiotic effect, beta-lactams and vancomycin. Concentration-dependent that has a post-antibiotic effect, aminoglycosides, daptomycin, quinolones, fluoroquinolones, metronidazole, azithromycin, and ketolides, which there's only one that's on the market that's not getting much use. And we'll get into that later on too. Time-dependent with some, that it's concentration enhanced, so it's a little of both worlds. That'll make you lose sleep. It's like, what is it? I don't know. This is an interesting group because if you look at it, other macrolides, if you think about it, this is not really a macrolide because the ring structure changed. We'll get into that a little later. It's very close, but it's a slightly different, and so are ketolides. Most people would talk about it being in a macrolide class, but they're really not true macrolides because those are 14-member ring structures, where this one's 15, and this it has a little different side chain on it that makes things change. If you look at naming of things, when we start talking about beta-lactam antibiotics, notice that we have penicillins, cephalosporins, carbapenems. And why? Because you changed the basic underlying structure. Remember you had that 5-member ring structure on a beta-lactam? That's a penicillin. Well, once you changed it to 6 members, you can't call it a penicillin anymore. It's different. So the FDA mandates that you name it something else. So since some of these came from the cephalomycin group or the cephalosporin groups with different bacteria names, and that's what they ended up calling them, was cephalosporins. Carbapenems, different as well, because if you remember, the ring structure is a little different. There's no sulfur in that one. So the classes get named because the ring structures are a little different. The activity is still pretty much the same, although it does vary depending on the different chemical structures. And just to give you an idea with some of these, here's how we know these studies. This is some of Bill Craig's data from back in 1981, the year I was born, or not. It's the year I started residency here. Actually, no, not till '84. But this was a really old study looking at, here's a control you see with all the black circles here with this line, and then a quarter of an MIC, antibiotic concentration, one MIC, 4 times the MIC, 16 times the MIC, and 64 times the MIC. So what they did was have higher and higher and higher concentration from nothing to just a little bit, not even up to, it's a quarter of an MIC to 1 MIC, and then higher and higher concentrations of the amount of antibiotic it's going to take to inhibit 90%, and these I believe were MIC 90s, to inhibit 90% of the bacteria in these cultures. So what you see with tobramycin is that since this concentration is getting higher, the higher the concentration, the better the killing, right? Can you see that? There's with nothing. There's with a quarter of an MIC, 1, 4, 16, 64. So the higher the concentrations, the better the killing, because this is looking at growth in log 10. So realistically, you've only got 2 log, but it killed it all in about 2 hours, as opposed to 4. So concentration dependent. Quinolone, ciprofloxacin, same thing. But a little bit of difference. Once you got up to 16 to 64, it didn't make too much difference. But look at ticarcillin. Same thing, but once you get down to it makes no difference. You can add as much, you could give them a railroad car full of ticarcillin, and it's not going to make any difference than perhaps that 3 grams, 2 grams, or 3 grams that you gave them. So that there are differences between time-dependent, concentration-dependent killing. So which one of these do we pick? And obviously, those are all the questions. The one is what are we dealing with? And that's usually what we tell people. Get me the bug and I'll tell you the drug. And that's usually as simple as it gets. What's the major mode of resistance? And those are, depending on which of these that we're talking about, it's going to be usually alterations of penicillin binding proteins. Where's the infection? What's the local environment like? What's the antibiograms look like? So that's what's microassay. And usually they tell you through in vitro sensitivity testing, or actually the proper term is susceptibility testing. So if you tell me something was sensitive, I'm going to say you mean it's susceptible, because Fariba is sensitive. The bacteria are susceptible. Correct? You could be susceptible too, but we won't go into that right now. Penicillin classification, you see them listed on this slide with the naturally occurring penicillins like Penicillin G, PenVK, benzathine penicillin. So we're taking natural penicillin, adding some things to it. Benzathine is an oily type of an anesthetic, not a very good anesthetic. Ask people that get this injected into their gluteal area, not necessarily the most comfortable thing in the world. Or procaine penicillin. Procaine's also an anesthetic, again, not the world's best one. But these are ways of trying to give someone an injection and have it last for a period of time, because they're giving it into a muscle with a little slower elaboration or activation from the parent compound that was given. So some of these kind of take periods of time to get concentration levels that are reasonable in serum or in other tissues. One of the things that used to be around when I was a resident, and I couldn't for the life of me figure out where you used it, although some people liked it more for certain infections, but it pretty much went away, was Penicillin G orally. It's not very well absorbed. But where you give Penicillin V, the potassium salt of that, which is what everybody talks about, PenVK, that's really what it is, Penicillin V, a little slightly different formulation that's fairly well absorbed orally, even though you have to take it how many times a day? No. Well, you could if you want to, but yeah, 4 times a day. And of course, you're telling somebody at home, take this every 6 hours, and their eyes glaze over. And so, well, can I just take it 4 times a day? Oh, that'll do. Just don't take it every hour for 4 hours. That's not going to really help. And again, without getting into the pharmacokinetics, pharmacodynamics, but one thing I would want to make sure that everybody understands is if you're giving somebody intravenous Penicillin G, how frequently do you have to give it? Every 4 hours, because the half-life is really short. So at the end, basically, of around 2.5 to 3 hours, you pretty much renally excreted about 90% of the drug, unless you're giving something else or they're renally, compromised in some fashion or something else. Or you're giving a drug like probenecid. Remember that these are organic acids, and they compete for the organic acid pump in the kidney. So if you give something like probenecid, it's also an organic acid. They compete for the same site, and they kind of back each other up since they're competing for elimination. The aminopenicillins is ampicillin and amoxicillin, the anti-staphylococcal penicillins that came out. One that's not on there because it's not really used anymore. It's not available for human use, but it certainly is in microbiology because we get worried about it. Which one is that? Yes, methicillin. Or in other countries, it's called Medicillin. There's no H. So you might see publications from other countries talking about Medicillin. It's the same thing. That's why I actually called up somebody that I knew who had written a paper and they had his Medicillin. I said, did you catch that you all had this spelling error in your whole paper? And he said, what are you talking about? And I told him, I said, it just said Medicillin. And they started laughing. They said, that's what it's called outside the United States. I said, oh, so we make a spelling error? And he laughed and said, yes, you do. You should get rid of the H. And whatever. And then you see 2 of those, Oxacillin, Dicloxicillin, and then the anti-pseudomonal penicillins, the ones that are still around, is ticarcillin, which is a carboxy penicillin, and a ureiopenicillin is Piperacillin. And then we get into cephalosporins in 1st, 2nd, 3rd, and 4th generation. You see those listed. 1st generation basically had a little bit of different activity, and we'll talk about that when we start talking about cephalosporins and what some of these generations, which is really just kind of factitious. It was an easy way for us to remember coverage for them. It's like Star Trek's The Next Generation, not the same people, doing maybe a little different things, but just a way of trying to differentiate between these. So we'll talk about that in a second. So we already talked a little bit about Penicillin G. You can get it either as an oral, IM, or IV. As you know, it's dosed in units, so it's one of those things that we still have to be careful about when we're writing. It's always better to write units behind something than a big U, because sometimes people mistake that for something else and give an inappropriate amount of an antibiotic or something else, especially if you're giving insulin. 2 units might be mistaken for 20. 20 units might be mistaken for 200. That would be bad, unless they really needed it. Where is this still a drug of choice? With few exceptions for Treponema pallidum, Neisseria meningitidis, Group A strep, and actinomycosis. As you know, there have been some strains of meningococcus that have had some resistance issues, but not so much to penicillins per se. Actually, it was to fluoroquinolones for prophylaxis. Same as we've had some issues with Neisseria gonorrhea and quinolones for treatment. So probably didn't surprise too many people. We talked about long-acting and Short-acting forms, benzathine penicillin, and people hang around at least 5 days. Most people, it's around for over a week to close to 10 to almost 14 days, and some people probably even longer than that. So it depends on the volume of distribution, amount of body fat, and other things. But it hangs around a long time, but usually at fairly low levels. And if you think about that, that's a great thing to use in something that replicates very slowly, like Treponema pallidum, because it's almost like giving a small amount of continuous infusion penicillin. And that's what these depot injections really kind of do. It's very helpful if we can do that. Obviously, it'd be great if you had some other way of doing it besides using a needle and giving it into a muscle, but the duration of antibiotic administration with this, it works quite well. So what are some of the adverse reactions other than just a rash? Because that's the most common thing people tell you. I got penicillin when I was a child, I got a rash, and they said I should never ever get it again. Well, some of this could have been, and one of these is not even on there, but this whole kind of, quote, serum sickness, drug fever kind of issue, with really looking at some of the immunopenicillins like Ampicillin. If you give Ampicillin with some other illnesses like EBV, if you give it with mono, 95% of people are going to get a rash. But it's not a type 1 allergic reaction. It's more of a Hampton reaction that if you wait another week or two and then give them Ampicillin again, nothing happens. With this, it's very similar because it's what you see with the Jurek-Herxheimer reaction. If you give people penicillin and they actually have Treponema pallidum, if they don't have a rash, they have primary syphilis, and if they don't have a rash, they might develop one in 24 hours. If they have a rash, it can get worse in 24 hours. So sometimes people forget to tell them that can happen. Then they get a Herxheimer reaction, and guess what they do? They go to a walk-in clinic or an emergency room somewhere, and now I have a rash. My doctor gave me penicillin. Oh, well, you're allergic to penicillin. You should never have that again. When in fact, wait a week or so, and you can give this and not have a problem. But you see some other things on here: hemolytic anemia, pancytopenia, neutropenia. Usually those neutropenias are at really high doses. So generally fairly safe drugs. We've already mentioned a little bit about Ampi and Amoxicillin. They're still really helpful in things like Listeria, Listeria monocytogenes, and Enterococcus for the ones that are still susceptible to penicillins. They're a great drug. They work very well. So if you were going to treat Enterococcus, giving 2 grams for serious enterococcal infections, at least every 6, if not every 4 hours. You can go to every 4.
I don't want to interrupt. There
Sure.
is one like a extended release that is coming out. One of those on Amoxicillin once a day.
Yeah, and it's yeah. Well, there have been some other ones that have been interesting that have come and gone in the past, but yeah, you can actually. What people have done is to, if you really want to hedge the bet, then you can give people probenecid, which will tend to extend the dosing interval out some. But yeah, it wouldn't surprise me. Of course, now I have in here what people used to get for dental prophylaxis, which was a gram of amoxicillin orally an hour prior to their appointment for dental work if they needed to have it. But now that we have very few things that actually get prophylactic for dental procedures, but that's not as common a use as it used to be. It still is very integral in a lot of the H. pylori regimens. So that's another area to not forget about using, usually more amoxicillin than ampicillin. And what are some of the adverse drug reactions? When you see them listed, we already talked about with mono and due to EBV and non-allergic reactions. Amox is better tolerated orally and better absorbed. So about 90% of amoxicillin, most people 85 to 90% gets absorbed, where only about 55 to 60% or so of ampicillin gets absorbed. Although some people used to use that to treat salmonella in the past because it would get great concentrations still in stool. So it was a little bit more effective in treating those. But it's now we have other things, and some of the salmonella are not so susceptible anymore. So reasons to use and not to use. Oxacillin. And you could argue as well, almost the same in getting into there. Diclox and Nafcillin getting very similar. Again, usually more for susceptible staph. whether it's Staph aureus or Staph epi. And this would be a pretty potent dose if you had a really, like a meningitis or something else, but 2Q6 is a fairly standard dose, sometimes even a little lower, 1.5 to 2. It's a little less active against pen-susceptible isolates than penicillin is, so if you're going to use group A, if you're going to treat a group A strep infection, it's best to use plain old penicillin and not oxacillin, because actually pen's better than ox for strep. Staph, this works better. It's more active than vancomycin as well, because vanco is actually a second-line agent for staph infections, but because of resistance, that's where it really went up to first line. And because we overused it to get people out of a hospital because Medicare would pay for it, where that home health will not give this, because giving a Q6-hour drug or a Q4-hour drug is not something that home health can easily manage. So some of it we probably did to ourselves. You can now if somebody will pay for the pump. And it used to be a huge problem, is people would pay for the antibiotic, they would pay for a home health visit, but they wouldn't pay for the pump. So you couldn't do continuous infusion antibiotics, which actually works well, and we're not going to talk about today because of time. Oxacillin does have hepatic metabolism, so you don't really have to dose it for renal function, which is nice. One of the few beta-lactams you don't have to. But obviously you do have to worry about, in some people, some degree of hepatic toxicity with cholestatic hepatitis. Again, at high dose neutropenia, and one of the terms that I actually did see that as a fellow decades ago now was, it's called Beta-Lactam neutropenia. That high doses of beta-lactams, you watch your white count go down. Well, if it's at 16,000 and it goes down, that's great. But once it gets down below 5,000, keeps going down, that's not so great. And many times if you just reduce the dose or you stop the antibiotic, the counts come back. We also are anxious about using this drug in newborns because of the potential to cause kernicterus. Dicloxicillin, it is not equivalent to IV oxacillin therapeutically. It is an oral drug, but it's not really all that well absorbed. You're lucky if you get about 50%. It's better absorbed on an empty stomach. And the dose, if you're going to use it, 250 to 500 milligrams 4 times a day. It's been generic for a long time, but not a whole lot of people make it, and it's still not necessarily as cheap as penicillin. So if you go to get it, people sometimes say, why do I have to pay all that amount of money? Because there is a cost difference between this and penicillin. Then we get into some of the other drugs like Piperacillin, where it's really been more of an anti-pseudomonal drug, but obviously has other activities as well. And some of those you see listed there with Enterobacteriaceae. It is the most active penicillin and has remained so remarkably for decades against Pseudomonas. Not uncommonly used in combination with aminoglycosides or a quinolone in treating complicated Pseudomonas infections or perhaps some other resistant organisms. The problem was that there's been concerns about bleeding, and again the same issues with neutropenia, thrombocytopenia at high doses. The bleeding has to do with some of these with certain side chains. Do you know what the side chains that there was a lot of debate for many years about being associated with bleeding? There's two structures. One is an alpha carboxyl group, and the other is an N-methylthiotetrazole group. There was one cephalosporin-like antibiotic that actually had both. And that was the big joke, was if you wanted to anticoagulate somebody, you just gave them that antibiotic at a high dose, and which really actually never really happened. There was a lot of discussion about it, but in really randomized prospective trials that they really didn't see the bleeding that people were talking about. And the doses that we were using in the United States with an antibiotic that's gone off the market for a long time is called Moxilactam. It was in the cephalosporin. It was the 3rd generation cephalosporin, but I was kidding around many years ago with one of the persons I knew that was involved with the drug, and I said, this will never go, this will never work. And he said, why not? You don't like the spectrum of activity? I said, no, everything else is Ceph. This is Mox. It won't work. And then they had these issues and these concerns, and people basically quit using it in the United States, although it was still used in other countries, especially in parts of Japan, Southeast Asia. And then we get into one of the resistance areas to talk about, although we're not spending a huge amount of time with this, but I do want to talk about beta-lactamases because, again, we'll reinforce a lot of this later. These are going to be important to understand when you start looking at what kind of things are available to use. That beta-lactamases are made obviously by bacteria that are alive, that are trying to stay alive. They can either be one of two different types. They can either be constitutively made, they're just inherent to the bacteria, that they were born with it and they continue to make it, or that they acquired it. It's plasmid derived. So that they weren't resistant, but because of getting DNA from different sources or mutations, that now they've learned how to make certain beta-lactamases. So that it was an acquired resistance instead of being born with it, if you will. That's the difference between those two. As we talked about in gram-positives, this is excreted out and tries to keep it in relatively high concentrations close to the cell wall in gram-positives, where it's pretty much contained in that periplasmic space in gram-negatives between the cell wall and cell membrane areas. There's tons of these things, more than when I was a fellow, as we kept finding more and more and more of different kinds of beta-lactamases. They probably evolved from penicillin binding proteins or cell wall precursors that bacteria actually turned and adapted into blocking some of these sites. So they either mutated these penicillin binding proteins so that the antibiotics just don't fit in that enzymatic area very well anymore, so the antibiotic just doesn't work or has reduced activity. The other part is selective pressure. You know that there's these two camps in the past, and a lot of these studies were done by Eugene and Christine Sanders, who have since retired. They have a home in Florida and used to do a lot of research at Creighton University in Nebraska. They were doing a lot of this, as well as some of the other individuals who have either passed on or have retired. And there was this thing about selection or stable derepression. And those are terms that you're going to hear, so those are some of the things that we'll later on talk about to make sure that you understand. I remember being at one meeting, and the one thing that was tossed around was selection of resistance, and then Christine was talking about the meeting stable derepression of that, and one person went up to the microphone and said, what a great talk. Now I'm really confused. So what is it that drives resistance? Is it selection or stable derepression? She said, well, it's both. And he said, I can't take this. And he went and sat down because they do get to be a little confusing. But some of this is just by one single amino acid substitution you can cause significant resistance changes. And those are those extended spectrum beta-lactamases. So if that's not enough to put you to sleep, this table will be. Because that's when you start looking at all these different types. If you look, there's really only kind of 4 types of these groups, and this is what's called the Bush-Jacoby and Medeiros classification of beta-lactamases. There's group 1, 2, 3, and 4. 4 really are pretty insignificant, to be honest. Most of what you're going to hear is about 1s, 2s, and some with 3s. With this is looking at using a beta-lactamase inhibitor, and in this one's just clavulanic acid. Would it work against these kind of resistance? No, yes. Inhibitor resistant already tells you nothing's going to work against that. That's a beta-lactamase inhibitor. It will work for some and not for others. So we have 3 that have been out on the market for a long period of time. Besides clavulanic acid, what else do we have as beta-lactamase inhibitors? Sulbactam and Tazobactam and clavulanic acid. So those are the 3 that are still out there. So just to go on with a little bit of this is why it's important to remember where bacteria kind of fall. It's always nice to know, is Staph aureus a gram-positive or gram-negative bacteria? This week. I'm just waiting for it to change even that. So knowing in gram-positives, they're pretty much, you're looking at some of these, and some of the, anytime that you see the zinc, these are metallo beta-lactamases, which is also a very interesting class because we're seeing some interesting resistance happening with some of those over the last several years. In gram-negatives, it's either chromosomal, and you see this kind of breaking down into that whole group of things, or it goes on out to plasmid, so these are acquired. And you see some of these acquired things are the extended spectrum beta-lactamases and the cephalosporinases. These all fit into some of those type 1 beta-lactamases. Aren't you glad you came to this today? To put it into maybe a little bit better way of looking at this, ones that fit into ESBLs, as you see at the top, are these TEM class beta-lactamases, SHV, CTXM. These are very interesting. Have you heard of a bacteria called Kluvera? It's Kluvera. Kluvera, I'm sorry. It's basically commensal. It rarely ever causes human disease, but it does make a beta-lactamase. And other bacteria figured out how to get that beta-lactamase from this completely commensal bacteria. And that's where these CTXM beta-lactamases, some of the class A beta-lactamases, come out of. This should give you a clue. Oxa beta-lactamases, what do you think that that's resistant to? Oxacillin. So it's actually started out as just an oxacillin, but has become even a broader beta-lactamase. They're the ones that none of the inhibitor ones work against. Then there's the AMP-C type beta-lactamases, and the ones we're getting more interested in now, the carbapenemases, of which you see that the KPCs or Klebsiella pneumoniae carbapenemases fit into, as well as the imipenem type carbapenemases that actually are very selectively resistant only to imipenem. Other ones, the VIM ones, which is Verona integron encoded metallobeta-lactamase, something to break the ice at parties. Hi, do you have any Verona integron encoded metallobeta-lactamases around by any chance? And hope the answer is no, because if they do, run. But these are the things that when we start looking at is, why do antibiotics work? Why do you get these weird antibiograms sometimes? Why is it resistant to everything? Why is it resistant to everything but one thing? Why is it resistant to unison and aztreonam? And you're going, what is up with that? It's these different beta-lactamases, depending on what they're making. So it's become quite complicated, because it used to be, when Eli Lilly was a big powerhouse of making antibiotics into the 70s and 80s, nobody cared that much about resistance, because in 2 years they'd have a couple of more antibiotics out on the market that would probably take care of most of these problems. And we tried to stay a little ahead of the bacteria, but that's not what we have anymore. That companies are really not that interested in making antibiotics because it's not financially very sound to do so. So how do you evade beta-lactamase? Well, you can do what we just talked about, is you can make a beta-lactamase inhibitor. If you wanted to treat something that was making beta-lactamase, use something that's not a beta-lactam antibiotic. Simple as that. What could you use then? Use a quinolone, use an aminoglycoside, use something that doesn't have a beta-lactam ring, because if it doesn't have a beta-lactam ring, you can't inactivate it with a beta-lactamase, because that's that enzyme that opens up the ring structure. So that's one thing you can do. You can do steric inhibition, and that's what some of these broader spectrum penicillins did, because they had these big side chains on them, and it was the steric inhibition that the enzymes couldn't get close enough to the antibiotic, to the beta-lactam ring. It was kind of protected by these side chains, so you could do that. So penicillin's large side chains and some of the cephalosporins, because again that ring structure is a little different beside the beta-lactam nucleus, or to combine it with the beta-lactamase inhibitors. But remember now that not all beta-lactamases are inhibitable, as you saw. Some are and some are not. Then you get into using combinations with amoxicillin, clavulanic acid, or augmentin, and most of you know the spectrum of activity. Upper respiratory tract agents like strep pneumo, H flu, M. catarrhalis. You don't see atypicals, so no Legionella, no Chlamydiophila pneumoniae, or anything else in there. It does have some activity against susceptible Staph aureus, and the biggest problem with this is the GI side effects, unfortunately, and that's predominantly a lot of the clavulanic acid. Some of the older formulations where they used to put a lot of clavulanic acid into it got a lot of diarrhea. And then we got into this twice-a-day dosing, because it used to be even 4-time-a-day dosing, and people had quite a bit of diarrhea. And then you went to the 875 milligram dosing, is 500 and 125, the different products, a little bit better tolerable. People thought about using this to treat Neisseria gonorrhea because back in the late 70s to 80s, what we started seeing was called penicillinase producing Neisseria gonorrhea, or PPNG. And that's why we quit using penicillin compounds to treat it. Well, you could use this. This would work fine. But really, you'd need about 3 grams of the amoxicillin part, and then by the time you got to the clavulanic part of that, you probably would have significant GI side effect and probably diarrhea. And it's available in all different kinds of forms, liquids, tablets, and chew tabs. The suspensions are interesting. Obviously, lots of pediatric. Some children have seen this in their life. Mine also saw it at one point in their life for an ear infection. And I'm always intrigued by when the product insert says pleasantly tasting solution or suspension. If you want to find out, give it to a child. If it comes back to you in an aerosol or a liquid, it's not pleasantly tasting. Sulbactam combinations, that was Ampicillin's combination with Sulbactam. There are some other combinations in other parts of the world looking at this as well. But in the U.S. we have Unison, which is that one combination. Again, what you're doing is expanding the spectrum of activity, because things that make beta-lactamase like H-flu and others that inherently make quite a bit of beta-lactamase now, it does work quite well for those. So you've regained the potency of this antibiotic with a lot of those. So E. coli Proteus, obviously not Pseudomonas, so it's actually not a bad drug for mixed infections. But we're starting to see some resistance even to that, as I showed you on that antibiogram the other day, that this drug has kind of really fallen off as years have gone along because of a lot of other kinds of beta-lactamase production that is not inhibited by Sulbactam. So in the past, where people like to use it was in diabetic foot infections, if there wasn't Pseudomonas involved with that, or other wound infections. And actually Sulbactam, at least in vitro, actually has really good activity against Acinetobacter, and that's why some people like to combine Unison with some other antibiotics to try and use really more the Sulbactam, but that's not probably the best thing to do anymore. Some of these are still susceptible, but even that's got to be around 70% or so of the Acinetobacters. And then the last combination with Tazobactam, and that was Piperacillin, Tazobactam, or Zosyn, which is still out. Actually, is generic now, I believe, but obviously nobody else is making it except for Wyeth still. Although that probably will change later on this year as other companies start getting interested. It is the most broad spectrum penicillin that's out there in the penicillin class. And so you see the dosing, and the recommendation is higher dosing, 4.5 grams Q6 for Pseudomonas infections, but 3.375 for others. Which used to drive me crazy because you were always dosing 3 gram, 2 gram, and then this came out to 3.375. But part of that's the Tazobactam added on to it. And then getting into those wonderful cephalosporins, and remember that no cephalosporin is effective against Enterococcus. They used to report this out in vitro. Sometimes they can look like they're susceptible, but clinically they don't work. So any cephalosporin, doesn't matter, is not a drug to use for Enterococcus or Listeria. It just doesn't work very well for Listeria either. The first generations had great gram-positive activity, not much. They had some, but minimal gram-negative. The second ones had better gram-negative coverage, but a little less activity against gram-positives, and that's really the way that things went. As you went, quote, up the generations, that you got better gram-negative activity and lost gram-positive. I do remember seeing an advertisement for Cefepime one time, and it said excellent gram-positive activity, and after I quit laughing profusely, I thought, I think that's a little overstatement. It might be reasonable in some cases activity, but I wouldn't say excellent. So you get into Cephalexin, Cefazolin, as some people call it, because this became very popular. Cephalexin, everybody was on euphemistically reflex Keflex because it worked great. Side effects were minimalistic, and it worked until we got into using it a lot, and then things became resistant. It was stable versus staph penicillinases, so it even worked against some of the penicillin-resistant staph, which was one of the reasons to use it. It also worked against penicillin-susceptible strep pneumo, Although, as I mentioned to you the other day, that's really pretty much a non-issue anymore because of the newer breakpoints in looking at strep pneumo outside of the CNS in lung that you really can get away with using this drug fairly effectively. It was used and still used for surgical prophylaxis, bacterial peritonitis in patients who are on peritoneal dialysis. It doesn't get into CNS very well, and there were a couple of adverse drug reactions as well. It's all the cephalosporins at high dose could be associated with leukopenia, and it was associated with a positive Coombs test, but rarely with hemolytic anemia. That's one of those things that people thought about. Second generation was Cefuroxime, still available. This was available and still available IV or orally. Used a lot in pediatrics. It was used a fair amount in adults with respiratory tract infections, and you see a lot of those things listed there. One thing, don't take offense if you write it the other way, because people have even talked about it. I've seen it on the web. If you go to certain websites, when they start talking about viridin streptococci, that some people write strep viridins. There is no such organism as Streptococcus viridins. Why? Why, Sally?
Because it's actually like a group. It has so many.
It's a discussion of what it looks like on a blood agar plate. See, they're alpha, beta, or gamma hemolytic. And since viridins means it's verde, so it's green. Yeah. So they look greenish. So what is that? Is that alpha, beta, or gamma? How many people say alpha? How many people say gamma? How many people say beta? I will throw something at you if you say beta. Beta is no. It is hemolysis, but no. It's alpha hemolytic. Huh? Yeah. But it includes, a lot of the mouth organisms. So they're viridins streptococci. There are species in there, but the group is called viridin strep, and a lot of times the lab just won't speciate them because it'll take extra time and it's a little laborious to do it. So please don't write that. Why don't you write that? Because I've seen a couple of attorneys go nuts and say, well, they had this strep viridins infection and they didn't treat it. You go back and look, and it was treated completely appropriately for that. They're just grasping at something, and said, no, this is viridin streptococci. And yes, it's strep mitis and some other things. Said, no, it's completely appropriately treated. And it's not a concern. So uncomplicated CAP, especially Haemophilus influenza, where this had really good activity, and alternative treatment for acute otitis media and prophylaxis and cardiovascular surgery were actually Kleiner, who was at Vanderbilt, did this wonderful study years ago that showed it was superior in decreasing staph surgical wound infections over first-generation cephalosporins in cardiothoracic surgery, and that's why everybody switched to it. Cefotaxime was the first third-generation cephalosporin to come out, and you see the spectrum of activity. It's still not an unreasonable drug to use for respiratory tract infections, especially with pneumococcus. Also with Neisseria and gram-negatives, even beta-lactamase producing Haemophilus influenza, and on average usually around 70 to 80% of those are going to be beta-lactamase producing. It was a great drug to treat bacterial meningitis, especially in peds, for CAP, uncomplicated and complicated UTIs, pyelonephritis, and bacterial peritonitis. So it was came out I think marketed by Roche many, many years ago. And had the brand name of Clafuran. God, you're older than me. Ceftriaxone, obviously still around after this time, another Roche drug. And this one gets used in the STD clinic very commonly because it's one of the last things that we still have activity with. It is once daily dose. It's highly protein bound, so it has a very long half-life, and that's why you can give it once a day. It covers strep pneumo, most Enterobacteriaceae, and still there are very, very, very rare reports of resistant with Neisseria gonorrhea to this drug. You don't have to adjust it for renal insufficiency because of the amount of protein binding, and it's mainly excreted fairly amount in bile, so you don't have to worry about renal insufficiency because it has another pop valve to get out of the body in case that the kidneys can't let it get out that way. It gets out through through your biliary tree. It does get into CSF reasonably well, better with inflammation than without, obviously, and you see some of the drugs of choice for that, as we've already talked about. Some of the adverse drug reactions, it is something that I've seen a couple of times, is acalculous cholecystitis. The individuals have been on this drug for quite a while. You start complaining about right upper quadrant pain. You get a sono, and they say they see the typical, highly medical terminology, sludge. There's sludge in the gallbladder. I always like that. That's like, writing that somebody had, looking at their nails and they had really bad onychomycosis, to write down gnarly nails. Yes. So you know all about gnarly nails. I knew it. And again, elevated bilirubin and diarrhea, some of the other issues with this drug too.
How is the activity for anaerobes?
Actually not that great. It had some anaerobic activity, but it's not really a highly active anaerobic drug. Ceftazidime was the same, but even worse with anaerobes. It really has no anaerobic activity, which is pretty much what the thirds had, was not really very much. Some of the seconds, and I did mention that, was, and we still use them, like Cefoxitin and Cefatitin, were, it was very interesting because Merck didn't know what to do with this drug that they had. And they thought, well, how do we market this with other second-generation cephalosporins? Well, about that time, we got really good at identifying anaerobic bacteria. And on a lark, they said, wonder how well we do with that. And they actually did really well. So Methoxin was the brand name for it. So Cefoxitin was marketed for those others. And in addition, we cover all these. Well, nobody else had any data if they had any anaerobic activity or not. So they got this lion's share of all the anaerobic drug use because that they actually were visionaries and did the tests up front, and nobody else had any data. There were other drugs that had some activity as well, but it was very, very interesting marketing. They did a good job with it, I guess. Ceftazidime is one of the ones that you've heard a lot about recently, and obviously gram-negatives is the forte, not so much gram-positives, no anaerobic activity, and is primarily used more for Pseudomonas infections in a variety of different places. And that's one of the areas where we've looked at, some of these are not quite as likely to stimulate some certain beta-lactamases, but we're starting to see others like the extended spectrum beta-lactamases. And are we getting the stably de-repressed chromosomal beta-lactamase production? And that's another area that people are talking about. Are we just seeing bacteria that were born with this that have never really had any antibiotic pressure to stably de-repress that gene and activate it? And the other question was, since none of these have activity against Enterococcus, did it help facilitate VRE? Because when you gave this, you were giving vancomycin and cefepime or something else. Well, all it takes is for people to use vancomycin inappropriately, or we were treating C. diff with a lot of oral vancomycin, so we selected out VRE, and then to give a drug like this on top of that wipes out a lot of the other gram-negatives but allows Enterococcus to grow. Did that help facilitate that? And some people argue that it probably did, and other people are not quite so sure about it. We mentioned cefepime. You see it's listed not in the coverage spectrum. MRSA, C. diff, Burkholderia, Stenotrophomonas, and other gram-negative anaerobes. It works quite well for the stable and de-repressed chromosomal beta-lactamases, but not the extended spectrum beta-lactamases. It does hold up better than other third-generation Cephs against a lot of the beta-lactamases. So for hospital-acquired pneumonia, febrile neutropenia, these are some places where we more commonly use cefepime at this point. And since I think we found out that cefepime and ceftazidime are not poisons like people were talking about and associated with higher mortalities that they saw in a meta-analysis, and people worried about that for years, doesn't seem to be a problem. The carbapenems are very similar to penicillins. In general, usually broader spectrum. They are renally cleared, and just some of the AEs you see with it is rash, urticaria, and cross-reactivity, although significantly less than we were probably led to believe in the past. Imipenem at high dose can be associated with seizures. The rest tend to have less of an issue with seizures. And At high doses, there have been reports, even although I'm not sure about with duripenem, but that's kind of the new kid on the block. You will see this listed not only as imipenem when you give it, it's imipenem silostatin. Why? Why do you put silostatin in there? To decrease the renal secretion? Good thought. It does have to do with the kidney, but it's not the. It's the metabolism. What's it metabolized to? Yes, it's a dihydropeptidase. Yes. And what does that do? The first metabolite is nephrotoxic. And it's not active. So if you wanted to treat an infection in the urinary tract, so if you want to treat pyelonephritis or something, this wouldn't do it. But it would help kill the kidney. So if you add silostatin, it actually prevents dihydropeptidation. So you keep active metabolite going out into the kidneys. You keep the parent compound. So if it doesn't break down, then you don't get the nephrotoxic metabolite.
Now, is silostatin alone available by itself?
I'm sure you could probably get it somewhere.
We had a talk in VA, one of the pharmacists was talking about it.
Of just using silostatin?
Alone by itself.
Why? It doesn't have any antibiotic properties to speak of, really.
Well, per the study that the speaker was talking about, there is, and I can't remember.
Oh, yeah, there's,
Slides.
yeah, a little, but not much. But I would just go to another carbapenem. Makes more sense. Something else.
It's true that the cross reaction between penicillin and imipenem is because it's elastatin, or is the imipenem?
No, I think it's the imipenem. I don't think it's a silostatin because it's really more of a class effect. And we'll talk about that in a second. So here's what we've got: imipenem, meropenem, ertapenem, and doripenem, which are similar but a little different. They are very broad spectrum. They all do have some activity for penicillin susceptible strep pneumo. Actually, imipenem has an indication, an FDA indication for penicillin resistant strep pneumo. I'm not worried about that anymore with penicillin resistance. It's just, to me, in my mind, it's a non sequitur. If you give high enough penicillin, people do great with it. For MSSA, you can, but there are other things that you might want to use otherwise. And for vancomycin susceptible enterococci, but sometimes it does depend on which enterococcus species that you're looking at with imipenem, and the others are a little variable as well. And we have other things that are probably better to treat enterococcus. But if you were going to use this to treat a mixed infection, then that would certainly be something to look at. Gram negatives, most things, and more often than not, even Acinetobacter and Pseudomonas. Where things lack coverage was ertapenem, where you have no Pseudomonas or Acinetobacter coverage. None of these have any activity against Enterotrophomonas, Legionella, MRSA, or VRE. They're just not. If you're going to treat something that has any of those in it, you're going to have some other additional antibiotics to try and cover those.
That VSC's fecales only or both?
It depends on which one of these you're looking at. Imipenem, I think it was more fecalis, not faecium. It's a little bit more variable depending on which species you're looking at. And again, if I was going to use it as combination, if I was more worried that it was more of an opportunist instead of if it's just around and part of the infection as opposed to being the only thing you isolate, I would probably use something else if it was like the primary infection. But if it was an opportunist and there and might be adding something, that should
cover it.
Yeah,
Dory will cover all of those.
supposedly.
And how is Dory for Acinetobacter?
I don't think there's much data with Dory for Acinetobacter. I don't think it's a drug that really has much activity against Acinetobacter at this point.
Because imipenem is better than meropenem for Acinetobacter. I don't know that with doripenem.
Yeah, and actually both of those have kind of fallen off a little bit as well. We certainly had our share of MDR Acinetobacters at the VA. And then you see a lot of other things here with imipenem. The resistances, as we're starting to see now, they were pretty much immune for a lot of the extended spectrum beta-lactamases. That was one of the few classes that would work If you lost cephalosporins or broad-spectrum penicillins, you could rely on carbapenems because that they were pretty resistant to ESBLs. But guess what we're having to deal with now? KPCs or these carbapenemases. It's not only the Klebsiella pneumoniae, there's E. coli's and some others. So with imipenem, what you're looking at is that there's a decreased production of these outer membrane protein Ds, and imipenem uses that to bind to more than meropenem or ertapenem, so that you're seeing now increasing resistance to things like Enterobacter and Pseudomonas. There is an efflux system in Enterobacter that will pump out imipenem too, I believe. And I'm not sure if you can override that one by concentration or not. I'd have to go back and look. But meropenem actually has multi-drug efflux systems, and those can be a real problem. You can have increased MIC from meropenem but not imipenem, although we've seen it the other way around in some strains at the VA. But by the time I find this out, call them and say, can we send them to somebody to look at? They've already tossed them. So it would be nice if we had a huge freezer and we could just freeze some of these away. Yes?
KPCs, which are more like selective against carbapenem. But when I
Yes.
have ESBL, I mean, still,
It's, yeah, it's probably going to fall into that too. They're still going to have ESBL. And that's why nothing works. So this is just even adding more insult to injury. The salt in the wound. Although salt can be good for some wounds, but it's not for this one. Because generally what you're going to see is, we have seen a few that have been ESBL negative but KPC positive, where there have been a few other choices, but those are really few and far between. Most of them have seen other antibiotics over a period of time, and that's why not uncommonly you'll see them being ESBLs, and then you go and put the pressure on using carbapenems, and then they generate, some kind of carbapenem resistance, whether it's Klebsiella. We've seen it with E. coli once. Proteus. We have some at the VA. There's a Proteus mirabilis guy's got. I know he's got struvite stones, and so he has infected renal stones with this, and he keeps having the same bug over and over as UTIs.
My question was,
Yeah.
I was getting a little bit confused with the ESBL as a group, or include the carbapenem. Isn't it, you know, the carbapenem as a group
It
include the
it can.
So
It can.
Like ESBL will be already kind of resistant to the carbapenems a little bit, although that's not the case. Is that what-
Well, and you're correct, but sometimes this is not, something that's expressed. That you're right. I mean, you can induce it in some, and that's probably what happens, is that these are inducible, and that if we weren't showing people this, although sometimes they just start making beta-lactamases for no reason at all, but one of the other things that's gone back to, we're doing it with cattle or other things as well by giving them, some of these antibiotics. Yeah, that's what they used to use, actually just putting things in chicken feed and stuff. Well, here, put some penicillin in there. That'll keep them healthy. Then the next thing we have is penicillin resistance to things because we've given it at such low doses. Just to mention Amonobactams, we already kind of talked about that. These are the easiest ones. These are the most narrow spectrum antibiotics because they only cover aerobic gram negatives. No gram positives, no anaerobes. Only aerobic gram positives. So you do see some resistance, though, even with Pseudomonas, Enterobacter cloacae, and Citrobacter frundii. They don't necessarily work too well. Well, H3N doesn't work all that well for Acinetobacter stenotrophomonas either. So their spectrum isn't quite as broad as some of the other antibiotics that are out there, but they get into tissues very well, especially inflamed tissues, and are renally cleared. The big forte with this is if somebody is penicillin allergic, if they're anaphylactically penicillin allergic, you can give this because there's no cross-reactivity. Because now all you've got is that beta-lactam nucleus. You don't have all the side chains on. So there's nothing that looks similar sitting beside it. It's just that. And that's not what apparently is the allergen with this. It's really more the other side structures. Can you have somebody who has an allergy to H3N? Yes. Not common, but yes, you can. Then can you give them penicillin?
Oh, that's yes.
Yes, because they're completely different. So the highest risk with cross-reactivity of beta-lactam is in patients allergic to ceftazidime, because they're fairly structurally similar. But usually if it's just a rash, it's not a problem. If somebody says, I quit breathing, I coded and all that, you probably don't want to give them a beta-lactam anyway, just avoid the whole issue. But if it came down to where they had something and this would work and other things probably wouldn't, I think you could probably do that with no problem. You might want allergy to try and, and skin test them first and see. But this is the whole thing. Literature reports penicillin, cephalosporin cross-reactivity is, depending on whose paper you read, 1 to 10%. Most people quote that 10%. Cross-reactivity of H3 and penicillin or cephalosporin is pretty much essentially 0. The cross-reactivity of penicillins and carbapenems is around 5%. Some people would say 1 to 5%. That's what the data looks like. And I know if you're over at Moffitt, one of the other issues is, especially in the bone marrow transplants, is now they have somebody else's bone marrow instead of the one that they had. So what little that they have may not be enough to generate this, and they're on immune suppressants anyway. So we tend to probably see rashes due to other things that people assume are antibiotic rashes, because we're looking at them in an intact immune response. And I know there was a person who had a past history of being really allergic to fluoroquinolones, but they'd had a BMT and hadn't engrafted yet. So we gave them quinolone. They had no rash, they had nothing, because that immunity was gone. And now they had somebody else's in there that we would assume, I guess, wasn't allergic, but they hadn't really engrafted. So a lot of this is really, I'm not sure, when we go over and we see transplant patients or people who are getting chemo and stuff, how many of those rashes are truly antibiotics? How many of them are really, truly pain medications? Because they can give you rashes and other things. So it's just tough to know. And usually we end up stopping the antibiotics because we're always the offender with that, and change to something else, and then the rash persists, and then they say, oh, well, they're allergic to that too. And I said, well, just keep giving them stuff. They'll be allergic to everything. We can sign off because we have nothing to add.